Welcome back to eJournalClub, where we turn recent reproductive pharmacology research into 4 minutes you can use. Low-dose aspirin lowers preeclampsia risk by roughly 40%, but only when it starts early and only for some patients. Today's paper asks whether the vesicles shed by the fetal membranes can tell us why. Today's study comes from Pharmaceutics. Mahajan, Kumar, Jacob, and colleagues. From stress to survival, trophoblast-derived extracellular vesicle proteome captures aspirin-driven cellular reprogramming in a preeclampsia model. Pharmaceutics, 2026, Volume 18, Article 677, Open Access under a Creative Commons Attribution License. Most aspirin research in pregnancy focuses on the placenta. This study looks somewhere else. Chorion trophoblast cells sit in the fetal membranes at the choriodecidual interface. They share a trophoblast lineage with placental cells, and they express placental alkaline phosphatase, but they do a different job. They form the structural and immune barrier that holds the membranes together. How that layer responds to aspirin has been essentially uncharacterized. The authors propose that the chorion acts as a secondary responder to aspirin, and that extracellular vesicles released by these cells encode the cell's stress history. If that is true, vesicle cargo should separate injury from recovery, and should change depending on when aspirin arrives relative to the insult. An immortalized human chorion trophoblast line was challenged with cigarette smoke extract to model oxidative stress. Two paradigms were tested: prophylactic aspirin at 4 and 40 micrograms per milliliter given before or flanking the challenge, therapeutic aspirin given after it. Vesicles were isolated by ultracentrifugation and size exclusion chromatography, then characterized by nanoparticle tracking and immunoblotting for placental alkaline phosphatase, flotilin 1, and CD9, following the MISEV 2023 guidelines. Cargo was quantified by data-independent mass spectrometry, then interpreted through pathway modeling and machine learning feature selection. 3 biological replicates per group. Oxidative stress rewrote the vesicle proteome. Coagulation factor 10 rose the most, pointing toward procoagulant cargo. Milk fat globule EGF factor 8, which supports angiogenesis and inflammatory clearance, fell sharply. Pathway modeling predicted rising apoptosis and suppressed angiogenesis. That is a preeclampsia-like signature, and it came from the fetal membrane, not the placenta. Aspirin's effect then split by dose. Low-dose prophylaxis achieved a dual rescue. Predicted apoptosis fell and pro-angiogenic cargo returned, including vascular endothelial growth factor A, collagen 4A1, matrix metalloproteinase 14, caveolin 1, and myofurlin. High-dose prophylaxis reduced apoptosis but produced no angiogenic signature at all. The proposed explanation is selectivity. Low doses spare cyclooxygenase 2-derived prostacyclin. High doses do not. Timing mattered even more than dose. Aspirin given after the insult partially blunted apoptosis and necrosis, but it did not restore the angiogenic signature and it did not reverse the inflammatory program. Once that program was established, it was pharmacologically inaccessible. One honest caveat: secreted cytokines did not follow the proteomic prediction. Only the continuous schedule normalized the composite inflammation index, and the authors flag that discordance directly. Looking at the therapeutic arm data, we see a distinct contrast. Even when aspirin was administered after the oxidative challenge, the protein regulatory networks showed limited recovery, failing to restore the survival signatures observed in the prophylactic models. The chorion is not a bystander. It answers aspirin by reinforcing survival and structure rather than by driving vascular remodeling, and its vesicles record which regimen it received. An exploratory panel anchored by HSPA8, Serpin F2, collagen 4A1, and PLOD1 separated prophylactic conditions in this model. But this is one immortalized cell line, 3 replicates, and predicted pathway states. The panel is a hypothesis, not a test. What it points toward is worth the work. A liquid biopsy that reads whether aspirin is working instead of assuming it is. If the inflammatory window closes before treatment begins, what do we offer the patient who presents late? 50 likes on this episode unlocks the deep dive. Stay connected and grow together.